So what are some of the myths surrounding GLP-1 agonists like semaglutide and tirzepatide? My name is Dr. G, and I'm an internal medicine doctor in Hollywood, Florida, and I also consult on weight loss medications like GLP-1 agonists and office-based aesthetics. I have heard it all when it comes to GLP-1 agonists, and trust me, I'm just like you, scrolling social media like IG and TikTok, and you hear crazy things. The wildest things sometimes come from my very own patients when they come into the office inquiring about weight loss medications. It never ceases to amaze me how the experts that live next door, who've never been to medical school or who've ever read about any of these medications, have so much to say. But they're mostly heard by most of my patients, and they come in here with all types of questions. So let's talk about some of these myths that I've had to debunk and some of these things that I've actually had to look up to make sure that I was telling my patient the correct things. Myth number one, GLP-1 agonists cause hypoglycemia. The fact is, hypoglycemia can occur with GLP-1 agonists, but they are probably the least common side effect amongst all the medications that we provide for diabetes. The studies have shown that occurrence of hypoglycemia or low blood sugar with GLP-1 agonists are at the very bottom, especially for medications like Mounjaro. In most cases, in patients who are using the medication for obesity and have no history of diabetes, they're not taking any other medications for diabetes. And those patients who are just GLP-1 agonist users alone are at the very bottom for hypoglycemia. So that's a myth debunked. GLP-1 agonists all by themselves, not a very good medication to lower blood sugar all by itself. Myth number two, and this is a popular one amongst our fitness crowd, and maybe some of the folks who like to be more natural and want to keep medications pure and are out here saying that why are we using these medications for weight loss? The myth is GLP-1 agonist medications are for diabetes and only diabetes. That's a complete myth. Both Wegovy and Zepbound, which are related to Ozempic and Mounjaro respectively, have FDA approval for weight loss all by itself when the BMI is greater than 30%. If the BMI is greater than 27% and you have another comorbid disease outside of diabetes, we're talking about high cholesterol maybe, or if you have renal failure or something else outside of diabetes even, or if you have pre-diabetes, they're also indicated for weight loss. So that is a complete myth. Obesity is absolutely a disease that confers higher risk and mortality across the board. Higher risk for cancer, higher risk for heart disease, higher risk for peripheral vascular disease, higher risk for heart attacks, higher risk for CKD or renal failure, higher risk for strokes. Obesity is definitely a disease and it needs to be treated. GLP-1 agonists are doing an amazing job in that space. Complete myth to say GLP-1 agonist medications are only for diabetics. Here's a myth you probably wouldn't expect me to say. GLP-1 agonists always cause weight loss. That's not true. GLP-1 agonists all by themselves cannot cause weight loss because they are not regulating the weight. All they do as an incretin that goes to your brain, in the part of your brain that says, hey, you've eaten enough, is to ratchet that voice up. It ratchets up the sensation that you're full for a longer time. Fuller for longer means you're not going to eat much. But some people can defeat this. We are already defeating this even without the medication. Think about it. After you've had dinner for, a long time, you're sitting at dinner, you're having a good time talking to your friends, pretty full, you've eaten that whole steak, nothing to take home, sitting there talking a little bit longer, waiter gets lost for about 5 minutes, comes back with the dessert tray, you're good and full now. You still have a slice, don't you? That's you ignoring that same hormone on your own. The medication is a lot louder, I like to say, a lot more effective than the ones that you produce, but it can still be defeated. So yes, it may control blood sugar a lot better without any help from you, but you actually have to put in some work. So not every single person is going to lose weight. Some people even lose weight at a higher degree or faster than others. Maybe that's because of dedication. Changing their lifestyle is what really causes the weight loss, not just the medication all by itself. So losing weight 100% of the time because of GLP-1 agonists, that's a myth. Here's another myth. GLP-1 agonists are all injectable medications. That's not true. Semaglutide, for instance, comes in the oral form. It's called Rybelsus. You can get Rybelsus on a daily basis. You'd have to take a daily basis. That's the difference between the injectables, which are only once a week. Rybelsus you take every single day, and it has similar, if not exactly the same, profile and weight loss and diabetic control as the injectable medication. So patients who are afraid of needles, afraid of getting stuck, afraid of sticking themselves at home can still get the benefit of the medications through their prescriber. You can get Rybelsus, which is the oral form of semaglutide or Wegovy/Ozempic. And that, my friend, is a myth to say GLP-1 agonists are all injectable medications. Here's a myth I was just battling just today. GLP-1 agonists cause pancreatitis. Although it suggests some patients had some pancreatitis during the trials, there's been no connection with actual pancreatitis and the medication on a regular basis. So you're having patients with obesity, which is already a risk factor for pancreatitis, or diabetes, which is also a risk factor for pancreatitis, having pancreatitis while they're on this medication. We found no causality of the medication itself to pancreatitis. Of course, we're going to watch out for it. We have to keep our patients well hydrated. Make sure we watch out for any one of these side effects, such as abdominal pain, vomiting, anything like that that's maybe associated with the medication, and have a high suspicion for pancreatitis, of course, like in any other patient. But to say GLP-1 agonists cause pancreatitis, right now, that's a myth. Here is a myth brought to me by one of my diabetes type 1 patients. Hey doc, GLP-1 agonists can replace my insulin. Put me on it. No, ma'am. GLP-1 agonists are not insulin medications and cannot be used in patients with type 1 diabetes. They do not replace insulin. Actually, GLP-1 agonists help the pancreas produce more insulin. It pushes the body to produce more insulin. It is not an insulin substitute. So it is a complete myth to say GLP-1 agonists are insulins all by themselves. And I'm sorry, right now, there is no indication for GLP-1 agonists in type 1 diabetics. Here's a great myth I saw on IG one time. Get off these medications. Don't you know GLP-1 agonists are addictive? Well, that's absolutely false. GLP-1 agonists, again, they mimic a hormone that we already make from our small intestines when we eat. There is no addictive property to GLP-1 agonists that we know of, and I really don't see how it could be. It doesn't touch any of the receptors that have anything to do with addiction at all. There's no withdrawal when you come off of the medication at all. I've had patients who don't feel well on it, or economically can't pay for it, or just missed their dose, or just couldn't get their medications because the pharmacy couldn't produce it on time, and there's no withdrawal from it. I've seen no direct deaths for overdosing on it. So yeah, sorry ma'am, GLP-1 agonists are absolutely not addictive. That's false. Here's a myth that most people with insurance would like to be true. GLP-1s are covered by my insurance, doc. Just put in the script. That's true. I can put in the script and they are covered by your insurance, but the rules are super, super strict. Sometimes you have to run through 4 or 5 other medications and show that they were ineffective or you've had some sort of side effect by the other medications before we can get to approval for the medications. So yeah, it is a myth that the medication, kind of a sort of a myth, I guess, that the medication is absolutely approved by all insurance companies. Here's a myth I enjoyed debunking right here in my office because of the implication for the patient. Hey doc, I'm just way too old. I've been told that these medications cannot be used in older adults. That's simply not true. We may need to adjust the dosage and go a lot slower than we would in a younger adult because, you know, older people are a little bit more sensitive and the risk of a complication in an older person is not higher, but clearly the side effect may be worse for them. But that's not true to say that the medication can't be used in older adults. That's just simply not true. The indication is for patients who have type 2 diabetes that is uncontrolled, high risk for cardiovascular disease, high risk for kidney disease, or patients who are obese. It doesn't say anything about age. So if there is a benefit to be had from losing weight as an adult, this medication can be used. And the last myth that I'd like to debunk is that the medications are only effective for a short period of time. Well, first off, these medications are pretty much effective for at least a week. And in some patients, you can get the effect for at least 10 days to 14 days. They have prolonged effect of the medication. So that's number one. And if you're talking about short term, as in, oh, when it comes off, then yeah, of course the medication is not working because the medication is not in your body. But why are we giving GLP-1 agonists like semaglutide and tirzepatide? We're actually giving it as a bridge so patients are losing weight, getting positive feedback, getting the benefit of weight loss in the moment while we coach lifestyle modifications, changing in the way they relate to food, changing in the way they relate to activity, changing the way that they relate to exercise. That's the long-term benefit of being on the short-term medication for about 3 to 4 months. But think about it. Diabetic patients are on the medication pretty much forever. They can be. There's no reason why we need to stop it. There's no benchmark for stopping the medication for diabetics. So why would there be a benchmark for stopping the medication for weight loss? We don't want a patient to lose weight down to, from 200 pounds down to 99. We can possibly use the medication as a maintenance for those who are continue to struggle with the lifestyle modification that we expect to happen with the medication during the time they're on it. I have had patients who have come in and said, hey, I was on the medication from another provider and I was only using it every 2 to 3 weeks just to make sure I get over and not go back into my bad habits. I've lost the weight that I need to lose and I wanted to lose. I'm to my goal weight, but I'm just not ready to just come off the medication. They are on maintenance therapy every 3 weeks, every 2.5 weeks, just a touch of medication, the smallest dose, to keep those cravings away, and they're doing just fine. Labs look good, weight looks good, and they are continuing, maybe increasing their intervals, and I believe they're gonna be off the medications anytime soon. Those are some of the myths involved with treating our patients here in Hollywood, Florida at my practice. And I'd like to hear some of the myths that you've been hearing, some of the things that you hear from your friends. Leave them in the comments down below, and let's talk about it. Let's do some myth busting. See you soon.